Mr. Kadir, Pervez Saab, Usma, Abid, and my senior colleagues, Assalamu alaikum. It's real tough to present any paper early in the morning when the people are not charged. But let me try to do it. I'll start तस्कीन मोहब्बत के बस दो ही तरीके थे, या दिल न बना होता या तुम न बने होते. Today is a good day for me to appreciate my colleagues who did a lot for the perfusion and how they improved the quality of perfusion in Pakistan. Just a simple background. After innovation of the first heart lung machine in 1953, the cardiac surgery became possible and routine. Both the heart lung machine and the extracorporeal circulation were improved by many innovation by the effort of senior perfusionists and manufacturers together. The safe use of new technologies require many different aspects which are developed to maximize the safety of patient. But before I start, I must say the cardiac perfusion program has started in end of 1971. Till now, we were be able to perform and train our juniors successfully. We have complete inventory. We have latest and advanced technologies. Perfusion technology is more advanced and safer because we have quality control now. Quality assurance, clinical indicator, protocol, policies, and of course benchmarks. Now the perfusionists are very well trained. The perfusionists have learned and adopted a new and improved technology, and you know how the perfusion technology become possible and routine in Pakistan. It's happened just because of these two leaders. Dr. Abdullah Khan, he was the first perfusionist of Pakistan who has trained abroad and came, and he started perfusion in Pakistan. And second, of course, Dr. Professor Muhammad Rahman. I must appreciate Dr. Rahman that in first step in 1998, perfusionists were busy to maintain the safety. We had presented few papers in cardiothoracic conferences. Professor Abdul Rahman invited senior perfusionists to present the papers. He allotted a perfusion slot in the conference. At that stage, we realized to work jointly. I can recall the first open heart in 1972. I am not so old. That my first case was the ASD in Pakistan in 1972. The case was very simple, ASD, but I primed my disc oxygenator with 6 units of blood. Can you believe it? At that time, there was no level sensor, no bubble detector, no line pressure, nothing. And on the other hand, nobody was there to assist me. Even people who are not ready to become a perfusionist. The same patient I had operated, I gave the perfusion in 1984 in Aga Khan University Hospital, where I have everything with me, a lot of assistant and junior staff. So the first assignment started in 1998 to identify the low volume priming oxygenator in adult patient. Hemodilution was a major issue for all of us. First task was given to Mr. Pervez and Mr. Farooq from NICD to identify low volume priming oxygenators for adult patients. At that time, we have the plenty of oxygenators, 13 types of the oxygenators. And finally, they came up with the solution and identified 3 oxygenators. So that was our first. In 2000, the low volume priming oxygenator was identified by the Azhar, is our colleague in Lahore, in pediatrics. Minimize the tubing circuit in adult cardiac. My late colleague, Mr. Pervez Bhatt, he worked a lot for the Lahore. He minimized the circuit, he designed the circuit. By that, we were able to cut down the size of the circuits and reduce of the prices. Blood cardioplasia was started in 1994. The usage of blood cardioplasia was a major change in perfusion. Myself and my group started this technique, and after successful result, we shared our experience and techniques to the other perfusionists. Other perfusionists also learned and adopted this technology. It was a big, real change in Pakistan. Blood cell saver started in 1992. Blood cell saver, AQH perfusionists worked very hard to finalize it. And look at the hemoconcentrator. Myself and my NICVD colleagues, they started in 1993 the usage of the hemoconcentrator, and successfully we got a good results, and we presented a lot of paper about it. Centrifugal pump, my colleague Mr. Hubert Haider in Shafa International Hospital, Islamabad, he worked very hard and he started usage of the centrifugal pump. As you know, the usage of centrifugal pump means protection of the RBCs, because the using of the roller pump ruptured the RBCs. Another, my friend, Mr. Ejaz, Zahid and Faisal Kabir, they modified pediatric tubings, diameter, size bravely, and they come up with a new design, and that was very nicely effort. It has been appreciated nationally and internationally both. Modified ultrafiltration MUF started by Mr. Tariq and Firoz Shah in AFIC in 2002, and the use of modification ultrafiltration has been in 2002, and it caused increase of hemoglobin, hematocrit, and total protein in the patients. I must appreciate Mr. Hafiz in Multan Institute of Cardiology, and Ms. Uzma is an ICVD. They both started online blood gases in their centers, and they share their practice to us. Microplegia and miniplegia, the advantage of non-diluted cardioplegia are many more than just a blood conservation. By this technician, hemodilation is less and cost effective, although blood microplegia have a lot of other benefits. Mr. Arif and Mr. Zain worked together hard, and the first time they introduced this technology in Pakistan, and they shared their experience. Unfortunately, it was failed due to the bad results. Vacuum assist venous drainage, my colleague Mr. Zahid and Mr. Abid Jabbar and Faisal Kabir, they introduced this technology in Pakistan in 1994, and since that we are working with the vacuum assist devices. How the retrograde priming, Kashif is here. Mr. Kashif Abbas and his boss, Mr. Arif, they both started this technology in Pakistan. And finally, we come up with the solution that by the retrograde priming, we can reduce more hemodilation and increase the hematocrit. And the height of the perfusion in 2013, first time in Pakistan, 40 days babies survive on artificial heart machine for 3 days. Yes, ECMO. Before we were thinking ECMO means the extra cash making opportunity. But now they did this, and it was a big, and I'm thankful to Kadir for promoting the ECMO in other centers. LVAD implantation, my NICVD Perfusionist 2020, the team worked very hard day and night to complete this task. Of course, we cannot forget this guy, Mr. Dr. Hasna Sharif, who joined us, who guided us, unlimited cooperation by the Dr. Hasna Sharif, and we are standing here. Thanks just because you, the quality perfume improved, because of the doctors, the surgeons, and the anesthetists. They give us a lot of protocols and guidelines. Our surgeon and anesthetists really work hard in 2011. Now the new challenges upcoming, wake up call for the perfumist. Upcoming challenges are ECMO in cath lab for PCI, ECMO in non-cardiac centers, involvement in TAVI, procedure in cath lab, LVAD, RVAD, and TAG. These technologies are coming in near future. So we have to come up with the new solution. the new perfumers must be active for this. Evidence now, ultimately, what is the goal? Evidence-based practice in all center, policies and procedure, perfume protocols, sharing of knowledge, peer review, data collection, CQI, and continuous education. Working together means winning together. Perfume is like riding a bicycle. Either you keep moving or you fall down. I can recall, thank you very much. It was a time to appreciate the seniors who work very hard and to improve the quality of perfume. Thank you.